Assalamu alaikum everyone. I hope everybody will come soon safely. We are here to discuss the continuity of topic of male or female infertility. Today we will discuss the treatment of male-related infertility. Okay. So Dr. Munazza will continue.
Bismillahirrahmanirrahim. Assalamu alaikum. So I'll be starting with the contents of the presentation of mine. We'll be discussing today the anatomy of the male reproductive system, causes of male infertility, EDO, which is ejaculatory duct obstruction, and turret, vasectomy, and vasovasostomy will be discussed. Assisted reproductive techniques, which will be involving in vitro fertilization, intracytoplasmic sperm injection, and intrauterine insemination will be discussed, and adoption. Okay, starting with the male reproductive anatomy, it consists of testes, which enters into epididymis, continuing into vas deferens, seminal vesicles, continuing with the prostate gland, passing through the prostate gland and bulbourethral glands, lastly penis. All these will be doing the functions of spermatogenesis, hormone production, semen production, and ejaculation. So basically, what is infertility? It is a failure to achieve a pregnancy after 12 months of or more of regular unprotected sexual intercourse, which is mainly divided into primary and secondary infertility. Primary infertility is inability of a couple to conceive a pregnancy after at least 1 year of regular unprotected sexual intercourse. And secondary infertility is further defined as inability to conceive or carry a pregnancy to term after previously having a successful pregnancy and birth. Okay, so the causes will be broadly categorized into pretesticular, testicular, and post-testicular. Pretesticular is further divided into hypothalamus and pituitary diseases. In hypothalamic diseases, we'll be seeing gonadotropic deficiency, which is also known as Kalman syndrome, isolated LH deficiency, isolated FSH deficiency, congenital hypogonadotrophic syndromes. And in pituitary diseases, we'll be seeing pituitary insufficiency, hyperprolactinemia, exogenous hormones, and growth of hormone deficiency. Testicular causes are further divided into chromosomal and non-chromosomal. In chromosomal, we're seeing Klinefelter syndrome, XX male, XYY male, and in non-chromosomal, we'll be seeing varicocele, cryptorchidism, Sertoli-Cell-Oni syndrome, and chemo and radiotherapy. Post-testicular causes includes congenital blockage of the ductal system, cystic fibrosis, acquired blockage of the ductal system, anti-sperm antibodies, and ejaculatory duct obstruction. Mainly in today's presentation, we'll be focusing on post-testicular causes because in urological aspect, we'll be seeing these things mostly. So what is...
These causes are slightly like every organ, like when you discuss the jaundice or when you discuss the renal failure, there is pre-renal, renal, post-renal. In infertility, there is testicular, pre-testicular, and post-testicular. The pre-testicular causes are here. There is hypothalamus, pituitary testes axis. We have to focus on. We have the basic knowledge of all these hormones, the corticotropins hormones and releasing hormones, and luteinizing hormone FSH, and where they act upon. All these syndromes have particular features like Kalman syndrome. There's gonadotropin deficiency, and there's another features of like 2 or 3 peculiar features which usually come in exam, and we have to know about the things. What is Kalman syndrome? If the patient is infertile and having anosmia, he cannot smell, he cannot have, then it is Kalman syndrome. Like when we see the cystic fibrosis, we know the basic concept of cystic fibrosis, and we have read a lot about it in terms of any pulmonary infection, bronchiectasis, or lung empyema, like these things. Cystic fibrosis also relates with the absence of cilia in the genitourinary system. So there is no traveling of sperms. So all these features can be picked clinically if we know the basic pathology of the syndromes. So this is very complicated but very easy to understand. So we will be discussing the treatment of post-testicular, because pre-testicular causes are complicated. We have to have the multidisciplinary team to manage them. Post-testicular causes we can treat by urologists by ourselves.
Okay, continuing with post-testicular causes, we'll be discussing ejaculatory duct obstruction. Ejaculatory duct obstruction is a condition where ejaculatory ducts, which carry the semen from the seminal vesicles and prostate to the urethra, and these the ducts are blocked. The blockage can lead to infertility, reduced semen volume, pain, and discomfort during ejaculation. These are can be congenital, acquired, and having a calculus. These causes are basically defined as congenital, acquired, and calculant. In congenital causes of ejaculatory duct obstruction, there comes atresia of the ducts, stenosis, or cysts of Mullerian ducts or Wolfram ducts, and neutrophil. In acquired causes, there could be infections like epididymitis and prostatitis, inflammation, trauma, or surgery. And in calculi, there could be stones of ejaculatory duct that also can cause obstruction of the ducts.
How many ejaculatory ducts we have? In any male patient, how many ejaculatory ducts? One, two, or multiple? And what is the basic definition of ejaculatory duct? How it forms? The two ducts, exactly you are saying, right? Two ducts, the duct which rise from the epididymis, the vas deferens, epididymal head, tail, and body, and then the vas deferens, the main. And then there is a duct of seminiferous tubules on both sides. They both they connect each other and they drain into a single duct. That duct is called as a ejaculatory duct, and they open in the prostatic fossa, in prostatic urethra, just besides the verumontanum. So when any obstruction in that ejaculatory duct is ejaculatory duct obstruction.
Ejaculatory duct obstruction can be complete, incomplete, or functional. On the parameters of semen analysis, these incomplete, complete, and functional obstructions are further divided. Below, sperm count, sperm motility, and ejaculate fructose content would be absent to low. Transurethral resection of ejaculatory ducts, known as TURED, can relieve obstruction into 60 to 65 to 70% males and shows the improvement in semen quality. 30% pregnancy rates can be expected after TURED. If semen analysis shows severe oligospermia, azoospermia with low volume and fructose is negative, so we can suspect the patient having EDO.
We can summarize this slide very quickly. Any obstruction has two basic causes. Number one, anatomical, and second is functional. The topics are very different, but we can relate like PUGO. There is an obstruction anatomical and there is a functional segment which is not peristaltic, which is not moving, which is not letting the flow out. Like here in ejaculatory duct, either there is some anatomical obstruction like from the stone, from the cyst, from the abscess, from trauma, from stricture, or there is a functional, like there is no cilia, there is no movement, there is accumulation of fluid but it is not draining outside. So the obstruction can be related to two particular basic causes, anatomical and functional. So both can be on the semen analysis, both can be diagnosed with multiple parameters like ultrasound, transsectal ultrasound to see the ejaculatory duct, to see the not to see the ejaculatory duct, to see the seminal vesicles diameter, seminal vesicular ducts diameter and length. They can be diagnosed easily.
So I have a describing video for TURED.
Can anybody tell me when they resected the ducts or the urethral cyst, which is one of the cause of EDO? What was the immediate finding when they de-roofed the cyst and they opened the ducts? There was a fluid white color semen which came out. If we collect that fluid and see under the microscope, the patient is fertile. We can see the sperms in that fluid also. Okay, and for the homework, what is utrical, yeah, utrical, whatever you say, whatever you pronounce. Utrical, it is an embryological remnant, but when it becomes enlarged, it becomes the cyst. It blocks the posterior urethra. It blocks the ejaculatory duct and can lead to the voiding symptoms and infertility also.
Can anybody of you can tell me what instrument we have used in turret? Okay, coming over the indications of turret, ejaculatory duct obstruction is causing mainly the first over in the indication is ejaculatory duct obstruction, for which we are doing turret. It is consisting of azoospermia, oligospermia, low volume ejaculate, which is less than 1.5 ml, having acidic pH, dilated seminal vesicles on truss or MRI, midline cyst, stones, and calcification, painful ejaculate, or hematospermia. There could be hematuria also, can be the indication of turret. Contraindications would be active UTI or prostatitis, uncorrected coagulopathy, suspicion of malignancy in ejaculatory ducts or prostate, large prostate size, and patient's preference for the least invasive procedure. The complications for the turret can be retrograde ejaculate, watery ejaculate, incontinence, infection. It can cause stricture or cause bleeding, erectile dysfunction, rectal injury can be occurred, inability to void or recurrence of EDO. The complications from the turret is approximately 20% patients usually have the complications of turret. Okay, coming over the vasectomy. What is vasectomy? It is a surgical procedure for male sterilization, often chosen as a permanent method for contraception. Usually, USA में ये चीज़ ज़्यादा हो रही होती है, not here at least. It involves cutting and sealing the vas deferens, the tubes that carry sperms from the testicles. This prevents sperm from being included in semen, thus preventing pregnancy. Nearly 6% males wish to get it reversed. And after reversal, 95% of males have the return of sperm after vasovasostomy, which is a vasectomy reversal procedure. Causes of vasal obstruction other than vasectomy includes infection. In congenital causes could be trauma or previous surgery. After vasectomy, we can check a patient semen analysis on the follow-up basis. Like before vasectomy, there are loads of sperm normal count in the patient's semen analysis. After 3 months, we can follow up the patient with semen analysis. It shows a decrease in count, and after 6 months, they're almost finished. So here is a picture which is showing, here the vas deferens are cutted and ligated. Same goes for the reversal of vasectomy procedure, which is vasovasostomy, in which we ligate both the ends of the vas deferens. In vasovasostomy, it is a surgical procedure to restore the flow of sperms after vasectomy. It involves reconnecting the vas deferens, the tubes that carry the sperm from the testicles. There are two main techniques for the vasovasostomy. Vasectomy reversal, basically. Vasovasostomy is reconnecting the vas deferens, and vasoepididymostomy is reconnecting the vas deferens to the epididymis, where sperm matures. Successful vasovasostomy relies on accurate mucosa to mucosa approximation, tension-free and leak-proof anastomosis with good blood supply and healthy mucosa and muscularis. Before attempting the procedure, we should check for adequate spermatogenesis and should be documented. Post-op follow-up with the semen analysis at 6 weeks, 3 months, and 12 months should be done. Here's a demonstrative video for vasovasostomy.
A vasovasostomy is one surgical procedure used to reverse a vasectomy. The animation provides a brief overview of the relevant anatomy, with the vas deferens, prior vasectomy site, epididymis, and testicle highlighted. The procedure is performed by placing the patient under anesthesia, after which a midline scrotal incision is made in the scrotum. This is usually not much bigger than is required to perform the original vasectomy. The segment of vas deferens that was previously blocked or transected at the time of the initial vasectomy is identified, brought through the surgical wound, and resected. After this, the fluid is sampled from the testicular end of the open vas deferens. This fluid is then analyzed under a microscope to determine if any sperm are present. In this particular case, an abundant number of motile sperm are visualized. This would suggest that we can proceed with reattachment of the vas deferens directly. To accomplish the reattachment, initial stitches are initially placed to reapproximate the vas deferens. After this step, several intraluminal smaller sutures are placed to bring the lumen of the vasa together. Additional sutures are then placed to completely enclose the opening of the vas, and final supporting sutures are placed to reinforce the newly attached vas deferens. Once the sutures are tied, the final connection is complete, and the vas deferens is returned to its normal location. The animation demonstrates the final result of a vasovasostomy.
I have a there usually in our exam, any exam, there is a question about when you are going to do the vasectomy reversal or vasovasostomy. You are planning vasovasostomy, and you have dissected the ligated or part on both sides, and from which side you will collect the fluid. And if the fluid is scanty and there is or no fluid, then what you will do? For testicular vasovasostomy, there is confirmed or written indication the spermatogenesis should be there for vasovasostomy, for vessel deconstruction. If there is no spermatogenesis in testes, then there is no need to do the to excise the stricture or fibrous part or vasectomy reversal. It means that spermatogenesis is there, you are going to do the vasovasostomy. You have to see the fluid on the testicular side of cut end of vas. If the fluid is scanty or very minimum, then you will do for vasoepididymostomy. And if there is the fluid is whitish and it is thick, it is copious amount, there must be sperm in it or there is no sperm, you will do the vasovasostomy. For this procedure, you have to have the microscope in the OR, because the stitch you used is 90. We have seen 60 or 70, but here 9 or 11 stitch which cannot be appreciated with our naked eye. We have to have some assistance of microscopy. The anastomosis should be, there is no speculation of ducts here. All the anastomosis in the urology, like ureter, we have to do the proximal and distal speculation. But here we have to cut the two ends, and then the anastomosis is carried under the vision, and anastomosis should be patent. Before the vasovasostomy, I have a question: how to confirm there is a vessel obstruction if the patient has no history of vasectomy? In the previous lecture we have discussed about it is a vasography. It's with the dye or with the very fine suture, you see it is going distally or not. And we don't put the dye towards the testis side, we put the dye towards the ejaculatory duct size.
Coming over the indications and contraindications of vasovasostomy. The indications for vasovasostomy is vasectomy reversal for restoring the fertility, and it could be due to post-vasectomy pain and vasal obstruction, which could be due to infection and iatrogenic injury. The contraindications include severe testicular atrophy, long obstructive interval, which is 15 to 20 years after vasectomy. Female partner is infertile, coagulopathy, and a chronic testicular pain or testicular tumor. The complications includes scrotal hematoma, infection, anastomotic failure or restenosis, persistent azoospermia or poor semen quality, chronic pain, and granuloma formation.
You can easily find the cut end of the vasectomy in an elective setting, but in trauma setting, when a patient comes to you with azoospermia, with inguinoscrotal previous history of any inguinoscrotal trauma, so how you will find the exact stenosed or cut end of the vas in trauma setting? You have to explore the whole testis, or you have to find a certain clinical or microscopic finding which will indicate it. This is the cut end, or this might be the ligated end. Like in our previous lecture, we have discussed that if you will not ligate the transected end, there will be a sperm granuloma. So in such cases, you have to find where is the sperm granuloma. You have to explore that end, and you can do the vasography and then confirm it.
There's another thing in trauma setting, like Dr. Faisal has said, like that will be not the pure urological setting. My microscope will not be there. Then there is another maneuver, sir. When we find the both ends, we just very fine suture, proline 7080. We pass through that, and if it is going freely, and the good length is went inside the vas, that means that there's no distal obstruction. If we don't have any microscope in OR, and if you don't have any CM to do the fluoroscopy of the or vasography, we can do this basic maneuver. But fluoroscopy is recommended for vasography.
At least our unit has got one added advantage, and that is of everybody, I think, has vascular surgery training or instrumentation. So if you are accustomed to use loops, so those visual loops actually would give you a little bit of edge over your naked eyes. So your own 6x6 vision, or maybe better if you try to use loops, and if you have done regular fistula making, then it pays you off on that area. So even in procedure, rather than having a naked eye maneuver.
Coming over the assisted reproductive techniques. Assisted reproductive techniques encompasses various medical procedures used to address infertility and help couples conceive. These techniques involve manipulating eggs and sperm either in the body or outside to facilitate fertilization and subsequent embryo development. These techniques include intrauterine insemination, in vitro fertilization, intracytoplasmic sperm injection, and gamete intrafallopian transfer. Intrauterine insemination is a fertility treatment that involves placing the processed sperm directly into a woman's uterus to help facilitate fertilization. It is a less invasive and more affordable alternative to in vitro fertilization. It is often recommended for couples with unexplained infertility, mild male factor infertility, and those using the donor sperm.
IUI or intrauterine insemination is a baseline fertility treatment that is used to improve the chance of conception. IUI is done in the case of women with mild endometriosis and cervical issues, men with ejaculatory issues, mildly reduced sperm motility or sperm count, and unexplained infertility. How is IUI done? In the natural process of conception, sperm travels through a woman's vagina, cervix, uterus, and ends up in the fallopian tube, where fertilization of the sperm and egg takes place, leading to an embryo formation. Due to some infertility issues, if this doesn't happen, sperm can be placed into a woman's uterus by IUI. IUI can be done in a natural cycle without the use of medications, or can be done along with ovarian stimulation as well. The first step in IUI is stimulation, wherein tablets and injections can be used to stimulate ovaries. The woman will have to visit the center for regular blood tests and scans to check the development of eggs. The second step is ovulation induction, in which trigger shots are given to induce ovulation. On the day of the procedure, the semen sample is taken from the male partner and processed in the lab to remove the seminal fluid. The next step is insemination, wherein the processed sperm is injected into the woman's uterus using a catheter. This is a painless procedure and doesn't take much time. For some women, additional hormone support is given to support the uterine lining for pregnancy. After 2 weeks, blood tests are done to confirm pregnancy.
Okay, coming over in vitro fertilization, the process where the eggs are fertilized by sperm outside the body in a laboratory setting, and then the resulting embryos are transferred into the woman's uterus. It includes following steps: ovarian stimulation and monitoring, egg retrieval, sperm collection, fertilization, embryo culture, embryo transfer, and implantation. The IVF is often recommended for the couples experiencing infertility due to various factors, including blocked or damaged fallopian tubes, ovulation problems, and the male factor infertility and unexplained infertility.
The first step is taking fertility medications in the form of shots to help your ovaries produce several mature eggs. The goal is to make 10 to 15 eggs. It takes about 2 weeks until your eggs are ready for retrieval. The retrieval process is a 15 to 30-minute procedure. The doctor uses an ultrasound to put a thin, hollow tube through your vagina and into the ovary that holds your eggs. The needle is connected to a suction device that gently pulls the eggs out of each follicle. Now comes the part everyone's most familiar with: combining sperm with your best eggs. In IVF, the egg and many sperm are left in a laboratory dish to fertilize on their own. The fertilized egg then divides its cells until it reaches the blastocyst stage 5 to 6 days after fertilization. Multiple embryos are then transferred back into your uterus in the hopes that at least one will implant itself and begin to develop. To find out how your baby grows and develops each month, please watch my next video.
Okay, so what is the difference between IUI and IVF? In IVF, the early embryo development begins in the lab prior to the transfer to the uterus. And in IUI, early embryo development begins in the body of the female. In IVF, it requires more medication and monitoring in comparison to IUI. And in IUI, it requires less medication and monitoring as compared to IVF. IVF chances of pregnancy per attempt is generally significantly higher than IVF compared to IUI. And the chances of pregnancy per attempt in IUI generally lower than IVF. And IUI is less invasive and less expensive procedure than IVF. IVF is generally more costly and than IVF. IVF provides an opportunity for fertility preservation through embryo freezing, which can increase the chance of pregnancy in both now and for the future. Intracytoplasmic sperm injections. It involves injecting a single sperm directly into the center of an egg to fertilize and to facilitate fertilization. This technique is often used when there are male factor infertility or when prior IVF attempts have been unsuccessful. IVF is used for female infertility, and unexplained infertility, or ICSI, is used when there is a male causes of infertility. The pregnancy rate per cycle was 13.1%. In IVF, eggs and sperms are combined in a laboratory dish and fertilization happens naturally. But in ICSI, a single sperm is directly injected into an egg to achieve the fertilization.
So now Donna is going to inject a single sperm into each egg that she has there on the dish. The sperm are placed into a viscous solution called polyvinyl pyrrolidine, or PVP is the acronym we use. And that slows them down. It serves two purposes. So it slows the sperms down so that we can catch them. It also makes it easier to control that fluid because it's a viscous fluid. So we're using suction to control the injection. Orientation of the oocyte on the holding pipette is very important. And data within our lab has shown that we get the best results when holding the polar body at a 7 o'clock position. So now what Donna's doing is bringing that sperm down to the very tip of the injection pipette. The idea of doing that is that we want to have no extra PVP injected into the egg. And also here at RMA of New York, we use a very gentle way of breaking the oolemma, which is the membrane of the egg, which is what Donna's doing there with the circular motion. So we don't actually break it by sucking in the ooplasm, which is the standard method. Due to this, we have very, very low damage rates with ICSI, which is something that other labs contend with up to 5%. You can see with this shot too how that micropipette is only just slightly larger than the sperm itself. So it's approximately the same diameter as a single human hair. So it really is very tiny. So now Dawn.
Gamete intrafallopian transfer, GIFT, is assisted reproductive technology procedure where eggs are retrieved from women's ovaries and mixed with sperm outside the body and then placed directly into the fallopian tubes of the female to facilitate fertilization. This technique is used to help couples with infertility issues, particularly when the woman has at least one healthy fallopian tube. It comprises of superovulation, egg retrieval, gamete mixing, and intrafallopian transfer. Concluding with the complications of assisted reproductive techniques, there could be multiple pregnancies can occur, premature birth or low birth weight, ectopic pregnancy, egg retrieval complications, psychological impact on the patient, infection, discomfort, ovarian hyperstimulation syndrome, and congenital anomalies of the kid. Coming over the adoption, it is the process whereby a person assumes the parenting for another and in so doing permanently transfer all the rights and responsibilities from the original parent or parents. There are multiple types of adoption. It could be open adoption, closed, domestic, and international adoption. The difference between the open and closed adoption is in open adoption, the adoptive parents are generally known to the parents' actual parents which are giving birth to the patient child, and the patient, the baby who is being born will also have a right to know the actual parents and the adoptive parents, and will be knowing the medical reports and any medical records. In closed adoption, both the parents will not meet by their end, and the patient, the kid which is being born, the patient would be not knowing the actual parents, or he would not be knowing the reason why the actual parents which has given birth to the patient are being opting for adoption. These are categories of adoption. In open adoption, both birth parents and adoptive parents maintain contact. In closed adoption, no communication between the birth and the adoptive parents. In domestic adoption, the adoption within the same country where both birth and adoptive parents are from the same country. Semi-open adoption is a limited communication through an agency or no direct communication between both the parties or parents. In intra-family adoption, relative adoption, the adoption occurs within the family like step-parents or grandparents. In international adoption, the adoption of a child is from another country. The indications for adoption would be absolutely infertility in either or both partners. The couple is not desiring or affording any medical treatment. There could be a genetic disease risk, transmission, and prevention. The contraindications for adoption would be there could be legal or social disqualification of the parent, like age limit or criminal records, previous criminal records, lack of stable relationship or home environment, and failure to pass the adoption screening. Okay, so I have a question in end. Which of the following is not a common surgical treatment for male infertility?
The correct answer is C. This is very good presentation with very good audio visual understanding of the mechanism.